everyone. Assalamu alaikum. This is Dr. Tazeen, your mentor and course director at Study MRCPI, and we are here with AAA series for all MRCPI aspirants who are preparing for their MRCPI Part 2 written March 2025 exams. The basic purpose of this series is to make you analyze your syllabus appropriately, to act wisely, and then to answer the questions appropriately and to achieve your success. If you have not subscribed the YouTube channel of Study Medic, subscribe now and just click on the bell icon so that you can get all the updates on time. And today's session is about operative vaginal delivery, which is the most exam tested area in your exam. And you should have clear idea that how to go about operative vaginal delivery, what are the indications, what are the various divisions of operative vaginal delivery and how it is being classified, and then moving forward, which is the appropriate choice of instrument and how to go about. I am Dr. Tazeen and I will be discussing with you operative vaginal delivery in this AAA series, which is for all MRCPI aspirants to make their exam preparation up to mark. So here we are with operative vaginal delivery, and the message for all of you before moving forward for the session is that keep your passion and dedication alive, which is the key of success. And all these things you will forget one day when you will be achieving your success. Then everything would be that you will forget about all these things. All right, so keep your passion and dedication alive, and someone who is having passion, then it is something that with passion everything is possible to achieve. And all these hustles, all these tough days, all these difficult days, they will be they are actually the antidote of your all problems, and it is leading you towards success. So don't be worried with these hard days. They are just for few days, and then you will be free and you will be able to achieve your success. So last 4 days not to be wasted in any way, and you have to focus on your studies. So basically, first of all, classification of operative vaginal delivery, they are basically classified into three categories: that the outlet operative vaginal delivery can be there, or the outlet cavity of the pelvis can be there. Then low cavity instruments are available, and then mid cavity instruments are available, and they're more about the forceps delivery, that when to apply for the outlet forceps, when to apply the low cavities, or when to apply the mid cavity. Outlet is basically the fetal scalp visible without separating the labia, and fetal skull has reached the perineum, and rotation does not exceed 45 degrees. When we talk about low cavity is that the fetal skull is at station +2 centimeter, but not on the perineum, and it is further subdivided into two subdivisions, that it can be non-rotational, that less than 45 degrees rotation is needed, or it is rotational, that more than 45 degrees rotation is needed. And then there comes mid cavity forceps. Mid cavity is basically that the fetal head is no more 1/5 palpable per abdomen. Leading point of the skull is at station 0 or +1, and then two subdivisions are again there, that non-rotational if it is less than 45 degrees, and rotational if it is more than 45 degrees, which needs to be kept in mind. Okay, so remember that whenever in the scenario it is given that the fetal head is visible on the perineum without separating the labia, that is the outlet. Okay, when it is given that the station is +2 or +3 but it is not on the perineum, that is low cavity. And when it is 0 or +1 station, then it is mid cavity, and the choice of instruments should be appropriately according to this. Okay, so outlet, again, the forceps, the fetal scalp would be visible without separating the labia, and it has reached the perineum. Okay, fetal skull at +2 station or +3 station, and it is further subdivided into non-rotational and rotational in case of low cavity, and then mid cavity is 0 or +1 station, which should be kept in mind. So basically, for the assisted vaginal delivery, marked capit can give the impression that the vertex is lower. But if in the scenario it is given that there is marked capit and you are unable to find that where actually the vertex is, that is not an appropriate patient, or that is not a right candidate for operative vaginal delivery. You should be able to assess the position of the vertex while going for operative vaginal delivery. And secondly, abdominal examination is also very, very important while embarking on operative vaginal delivery, as up to 1/5 or less than 2/5 should be available. When they say less than 2/5, that is also appropriate, or 1/5 of the head should be palpable abdominally when we have to go for operative vaginal delivery. So that is the right candidate. If it is given the head is 2/5 palpable, that is not a right choice to go for operative vaginal delivery. Certain contraindications for assisted vaginal birth are also there. If there are suspected bleeding disorders, bloodborne viral infections in the mother are there. Vacuum extraction is not contraindicated following a fetal blood sample. Procedure or application of fetal electrodes and vacuum birth should be avoided below 32 weeks. It should be done with caution between 32 to 36 weeks of gestation. Okay, so that is also to be very careful in the preterm, that if it is less than 32 weeks, vacuum is not a good choice. Okay, and then 32 to 36, stay cautious in cases of preterm labor. So what actually is the rule of operative vaginal delivery? That if vacuum and forceps is given and there is no contraindication for vacuum, you can go for vacuum first. If there is no capit, there is no molding, or there is no preterm less than 32 weeks, then if the forceps are given, then you have to first look at the station, that what actually is the station, so that we can come to know that whether it is low cavity, it is outlet, or it is mid cavity. Okay, if it is mid cavity, it would be station 0 and +1. If it would be low cavity, it would be station +2. And if it would be outlet, then the head would be visible at the perineum without separating the labia. In case of mid cavities, station is 0 and +1. Rotational forceps can be applied, which are Keyland's forceps. Non-rotational forceps can be applied Neville Bahn, Hitch-Ferguson, and Simpson's. Simpson's is used for molded head. Piper's forceps is used for the aftercoming head of breech. If that is not available, then Keyland's can also be used. Low cavity is +2 and +3. Simpson's and Wrigley's can be applied. And then outlet is when the head is visible at the outlet, and Wrigley's is applied, which is known as outlet forceps. So basically the key points to remember is that what are the contraindications? That is that vacuum should not be applied at less than 32 weeks. In cases of bleeding disorders, if there is capit or molding, face presentation, definitely on the face presentation, vacuum cannot be applied. Cephalopelvic disproportion is not a right choice to go for operative vaginal delivery. If there is no maternal effort, forceps can be applied, but vacuum cannot be applied. And in cases of fetal bradycardia also, to stay cautious. Now there is here comes an important exam question which we have to understand, that a 25-year-old woman who is 40 weeks pregnant in her first pregnancy is in the second stage of labor, and she has been actively pushing 2 hours and is exhausted. CTG shows a baseline of 150 beats per minute, normal baseline variability, occasional accelerations, and infrequent typical variable decelerations. She is contracting 3 to 4 every 10 minutes. Vaginal examination reveals full dilatation, and the fetal head is in direct occipito-anterior position at +1 station below spines. Which of the following is most appropriate next step? So primi gravida, epidural is not mentioned. In cases of primi gravida, second stage with epidural is 3 hours, without epidural is 2 hours. Epidural is not mentioned. She is actively pushing from 2 hours, and CTG is showing variable decelerations. Contractions are appropriate 3 to 4 in 10 minutes. And on vaginal examination, full dilatation and occipito-anterior position is there. So +1 is mid-cavity forceps. So cesarean section, no, we can go for operative vaginal delivery as she is having the head below spines. Episiotomy won't help in the delivery. fetal blood sampling is not recommended. Okay, oxytocin augmentation is not needed as she is already having appropriate contractions. So here the answer would be instrumental delivery. We can opt for instrumental delivery. And always remember that for the mid cavity 0 and +1, as this 0 and +1 is the mid cavity, we can go for instrumental delivery, and that would be in the operation theater after written informed consent of the woman. If it is the outlet forceps, or if it is a low cavity forceps, that can be applied in the delivery room, and verbal consent is needed for that. So here the answer is that safe operative vaginal delivery requires a careful assessment. She is primigravida, actively pushing for 2 hours without anesthesia. So that is acceptable to resort for instrumental delivery. And in the primigravida with epidural, that is 3 hours. Without epidural, it is 2 hours. And in multigravida with epidural, it is 2 hours. And without epidural, it is basically you can say that would be 1 hour. While for multiparous women, lack of continuing progress for 2 hours total of active and passive stage with regional anesthesia is 1 hour. That should be kept in mind in these cases, which is important. So what are the medical indications of assisted vaginal delivery? So that can be cardiac diseases, hypertensive crisis, cerebral vascular disease, malformations, myasthenia gravis, or spinal cord injury. What are the relative contraindications of assisted vaginal delivery? Fetal bleeding disorders, for example, alloimmune thrombocytopenia, a prediction to fracture, for example, osteogenesis imperfecta, if it is there. Fetal indications is suspected fetal compromise if pathological CTG is there. And then maternal indications for assisted vaginal birth in nulliparous women, that can be lack of continued progress for 3 hours, total of active and passive second stage with regional analgesia, and 2 hours without regional analgesia. In the multiparous women, that can be lack of continued progress for 2 hours of active and passive second stage of labor with regional analgesia, or 1 hour without regional analgesia. And then maternal exhaustion or distress. Medical indications to avoid Valsalva maneuver can also be among one of the indications of operative vaginal delivery. The safety criteria is full abdominal and vaginal examination before embarking on operative vaginal delivery. Maternal preparation and staff preparation is important, and the important abdominal and vaginal examination findings which are helpful for the operative vaginal delivery is that head should be 1/5 or less than 1/5 palpable, cervix should be fully dilated, membranes should be ruptured, station at the level of spine or below. If it is -1 station, then it is not appropriate patient for operative vaginal delivery, as mid cavity is 0 and +1. High cavity we cannot apply forceps. Okay, so 0 and +1 is mid cavity, so the station at the level of ischial spine should be there, or it should be below the ischial spine. Position of the fetal head should be determined, that whether it is occipito anterior, it is occipito posterior, or what is the situation. And capit and molding is no more than moderate, that is it should not be +2 or more. Pelvis should be adequate for going for operative vaginal delivery. Then the important aspects of preparation for the mother. What should be advised for the mother and how to prepare the mother. Clear explanation and informed consent. Women's case notes should be complete, trust established, and full cooperation sought and agreed with the woman. So she should be communicated appropriately what you are going to do and how it would be done. If you are going to do in the operation room, written consent is needed. If we are going to do in the delivery room, verbal consent is needed. Appropriate analgesia should be in place for mid-pelvic or rotational birth. This will usually be a regional block. Pudendal block can be acceptable depending upon the urgency, and perineal block can also be sufficient for low or outlet births. Maternal bladder should be emptied, indwelling catheter should be removed, and balloon should be deflated, and all aseptic measures should be used. Then the important aspects for the preparation of staff and safety criteria, that operator should have the knowledge and skill about the operative vaginal delivery. Adequate facilities and backup plan should be there, that if the operative vaginal delivery is failing, operation theater should be ready so that early recourse to cesarean section can be done. Backup plan for mid pelvic births, theater facilities should be available to allow a cesarean birth to be performed without delay, and a senior obstetrician should be present if inexperienced obstetrician is conducting the birth. Anticipation of complications should be there, that there can be shoulder dystocia, how to manage that, there can be perineal trauma, there can be postpartum hemorrhage. So all the emergency measures, all the equipments, and everything should be ready to manage these obstetric emergencies. And personnels present, who they should be trained for neonatal resuscitation, as if we are going for operative vaginal delivery, there can be complications for the mother in cases of shoulder dystocia, postpartum hemorrhage, perineal trauma, and there can be complications for the baby, that fetal distress can be there. So the personals or the neonatal staff should be available, and neonatologists should be available so that the baby can be immediately resuscitated if the need arises. Verbal consent should be obtained if it is the birth room procedure, and written consent should be obtained if it is operation theater, and these both are exempt tested areas. So what are the factors which are leading towards higher failure rate of operative vaginal delivery? That is maternal height to weight ratio more than 30, short maternal stature, estimated fetal weight of greater than 4 kg or a clinically big baby, head circumference above the 95th percentile, occipito-posterior position, mid-pelvic bursts, when we say mid-pelvic, 0 or +1, or when 1/5 of the head is palpable abdominally. So ideally it should be less than 1/5, but 1/5 we can go for operative vaginal delivery. Okay, so but if it is 1/5, then we should keep in mind that there are higher chances of failure rate. And always we have to keep in mind that when we have to discontinue vacuum assisted birth, and when we have to discontinue the forceps assisted birth. So in cases of vacuum assisted birth, basically discontinue when there is no evidence of progressive descent with moderate traction during each pull of correctly applied instruments by the experienced operator. If in the majority of the cases, maximum 3 pulls, if they bring the fetal head on the perineum, 3 additional gentle pulls they can be used for the delivery. And vacuum birth, it should be discontinued if there have been 2 pop-offs of the instrument. So if there is no descent with the 3 pulls, of there are 2 pop-offs, then this instrument should be discontinued, consultant opinion should be taken, and then it should be followed. While moving forward with the forceps, that when to discontinue the attempted forceps birth, when it cannot be applied appropriately, both the handles they should lock appropriately, and if it is not applied appropriately, then there are higher chances of failure, so it should be discontinued. If the rotation is not easily achievable with the forceps, then also it should be discontinued, as there can be trauma to the baby. And if birth is not imminent following the 3 pulls of a correctly applied instrument, also it should be discontinued. And if there is minimal descent with the first 1 or 2 pulls of the forceps, the operator should consider whether the application is suboptimal, the position has been incorrectly diagnosed, or there is cephalopelvic disproportion, that this is not, the head is not descending. So all these things should be assessed, and if the need arises, the forceps delivery should be discontinued, and we should proceed for cesarean section. While performing mediolateral episiotomy, it should be 60-degree angle initiated when the head is distending the perineum. So another exam tested area, that Mrs. XY is primary gravida at 40 weeks in the spontaneous labor. She is of Asian ethnicity and she has a baby in occipito anterior position. She has been pushing for 1 hour using epidural analgesia. Birth is imminent. Perineum appears overstretched and distended. What angle of mediolateral episiotomy is likely to prevent occult anal sphincter injury? 30 degrees from the midline, 40 degrees from the midline, 45, 60, and 90. So we just have concluded that the episiotomy should be at 60 degrees from the midline, with careful attention to ensure that it is 60 degrees away from the midline when the perineum is distended. Okay, then another question, that full term pre-labor rupture of membranes, fully dilated, head is 2/5 palpable abdominally, station is at spines, meconium stained with decelerations and reduced variability. So if we have a look at the gestational age, she is good for operative vaginal delivery full term. There is pre-labor rupture of membranes and full dilatation is also there. But head is 2/5 palpable. So if head is 2/5 palpable, then it is not an appropriate candidate for a vaginal operative vaginal delivery. So we should go for cesarean section. Now there is meconium and decelerations are there and reduced variability is also there. So that would be category 1 cesarean section. If they give you that CTG is normal, there are no decelerations, then we can go for category 2 cesarean section. But here it is that abnormal CTG is also there. So that would be category 1 cesarean section. Full term fully dilated head is 0/5 palpable, abdominal station is +2, occipito posterior, meconium stained with decelerations and reduced variability. So what to do? So if we have a look at the station that is full term, that is pre-labor rupture of membranes, patient is fully dilated, head is 0/5 palpable. So all these are basically good to go for operative vaginal delivery. Station is at +2, that is again a low cavity. Okay, but it is occipito posterior. So we discussed that there are higher chances of failure of operative vaginal delivery with occipito posterior position. So this delivery should be undertaken in operation room. Written consent should be there. And then we can go for category 1 lower segment cesarean section. No, this is a good candidate to go for operative vaginal delivery. Forceps delivery in operation room, yes, that is the right option. Forceps delivery in labor room is not an appropriate option for the occipito posterior delivery, as there are higher chances of failure. Outlet forceps +2 station is not outlet forceps. So we should take care and we should keep in mind that +2 is low cavity and occipito posterior is an indication to conduct delivery in the operation theater after written consent. Okay, so that is something we should keep in mind. Full term pre-labor rupture of membranes, fully dilated, head is 0/5 palpable abdominally, station is +2, occipito anterior, meconium stained liquor, decelerations are there and reduced variability. So full term pre-labor rupture of membranes and 0/5 head palpable abdominally, and that is a good indication to go for operative vaginal delivery. +2 is a low cavity. Occipito anterior is associated with higher success rate of operative vaginal delivery. So we can go for operative vaginal delivery as there is occipito anterior. So this delivery can be conducted in the labor room with verbal consent. So category 1 cesarean section is not the right option. Forceps delivery in the operation theater is done for the mid cavity as well as for the occipito posterior. Forceps delivery in the labor room is right option for this patient in case of low cavity occipito anterior, and outlet forceps is not the right option at that is low cavity. It is not an outlet. So here the answer would be C, that we have to go for operative vaginal delivery in the labor room. So that is all about the operative vaginal delivery. I hope this will help you in your exam preparation. So just remember the basic rules of operative vaginal delivery, that you have to see the abdominal and vaginal examination findings. You have to see that cervix should be fully dilated, abdominally it should be 1/5 or less than 1/5 palpable, and then determine the position, that whether it is occipito anterior, occipito posterior, occipito transverse, and at what level, what is the station. And then by dividing into low cavity, mid cavity, and outlet forceps, you can choose the forceps appropriately. And then always remember that if there are any risk factors which are available, which are leading to the higher chances of failure of operative vaginal delivery, then this delivery should be carried out in the operation theater after written consent. Otherwise, this can be carried out in cases of low cavity or outlet when rotation is not needed, in cases of occipito anterior in the delivery room, and that is done by verbal consent. I hope this will help you in your exam preparation. We at Study Medic wish you all the very best for your upcoming exam results. Have a great day. Thank you.